kick us off, I wanted to just say good morning or good afternoon to each of you, depending on where you are logging into us from this morning. I'm just delighted to see so many familiar names and faces joining us today. And for those of you that I haven't had the pleasure of meeting just yet, I'm Andy Hollowell. I'm the Chief Growth Officer here at Lightfully Behavioral Health. And we wanted to welcome you to our continuing education event, Lighting the Way: Interventions for Teens and Their Families in Navigating Teen Suicide Risk. Before we dive into our main presentation, I wanted to share just a couple quick updates with you all about our services here at Lightfully. As many of you know, at our core, we are just so dedicated to changing lives compassionately. And we specialize in primary mental health services here, serving both adults, so 18 and up, as well as teens, ages 12 through 17. And at our gender inclusive programs, we welcome clients of all identities across our locations in Los Angeles, San Diego, Thousand Oaks, and up in San Jose. We really pride ourselves on making quality mental health care accessible. And the way that we do that is through extensive insurance coverage, really strategic location choices, and really just an unwavering commitment to clinical excellence. In particular, I'm excited to announce our newest addition, which is a virtual PHP program that has integrated psychiatric services that expands our access to care and allows us to reach more clients while maintaining a really high standard of psychiatric oversight that they need, all from the comfort of their home. And speaking of expanding access to care, we have also just launched our holiday short-term option. This innovative program offers intensive support across all levels of care, from residential through virtual programming, starting conveniently in 2-week blocks. So it seamlessly, complements existing outpatient treatment during high stress holiday periods, and also provides comprehensive support through daily groups, individual therapy, and also family sessions, all led by our licensed clinical experts. And if you think that this sounds like a good fit for either one of your clients or a loved one, our admissions team is always ready to facilitate a smooth transition for your referrals. I'll also go ahead and include our admissions team contact information in the chat so that you can have that on hand for reference. Also, just to know, today's presentation is going to be available afterwards online, and we're going to address all of your questions in our Q&A session at the end. So please feel free to drop those either in the chat, or I think there's a little Q&A box down there at the bottom. And now it is my pleasure to introduce our distinguished speaker this morning. Dr. Nicole Siegfried is Lightfully's Chief Clinical Officer, and she brings with her over 2 decades of mental health treatment expertise. And her expertise spans eating disorders, mental health, and also suicide prevention, with numerous publications and international speaking engagements to her credit. She is also one of the kindest, funniest, coolest people I know. So I am so excited to introduce you to Dr. Siegfried this morning. She really just has this unwavering belief in recovery and a dedication to helping individuals build lives worth living. And that has really shaped our approach here at Lightfully. So without further ado, I want to hand it over to you, Nicole, and you can kick us off with the presentation.
Thank you so much. Let me share here. All right. Well, we're so glad you're here. And I will echo what Andy and Shelley said in terms of apologies around the link. This just already shows your resilience and resourcefulness. That we'll talk about some of those things today and preventing suicide risk. I like to start a little bit with my own story of how I got here. My area of expertise was eating disorders, and in working with eating disorders, some of you who may work with eating disorders may know that eating disorders have one of the highest suicide risks of any psychiatric disorder. And I'd found myself in working with that population really at a loss in terms of how to meet their needs around suicidality. So back in like 2010, 2011, I really began my own exploration of what techniques could I bring to my clients to really meet their needs in this area. So whatever that phrase is, that necessity is the mother of invention, I became somewhat of an expert in that area of the overlap between suicide and eating disorders. And in working in that field around the time of COVID, we really saw a spike in depressive symptoms in our clients. We really saw a spike in suicidality. And our clients were left with very few resources of where to go, how to get help after a suicide attempt. And we'd be trying to refer people places, and there would be no place that would take them because they would say, you have to have some space between your suicide attempt and treatment, which never made sense to me. So part of what went into the creation of Lightfully was a need to serve these individuals specifically. We wanted to be a space for individuals who are struggling with suicidality, a space for individuals who may not be accepted into other programs. And that is at the foundation of who we are. And indeed, 80% of our clients are struggling with elevated suicide risk. Today, I want to talk more about our teens specifically. And if there's a paucity of research in suicide in general, that those limitations are amplified when we look at teens. There is very little out there in terms of evidence-based approaches. I'll talk about some of that today. So you as clinicians, I'm sure, are grappling with, how do I meet the needs of my teens and their families? Because this isn't an area that has been well researched. One of the things that I like to do in my presentations is to make accessible the toolbox of skills and techniques that I'm going to be talking about today. So this flow code has a direct link to this slide deck and to all of the interventions we discussed today. So you can use that now if you want, and you can get a direct link into the slides to follow along, or you will also have access to this link at the end to get them at the end. So what we're going to do today is start with what I think is the most important aspect of working with suicidality, which is understanding the suicidal mind. It's very complicated in terms of what's behind that desire to die. So that's a good place to start for us as clinicians, and definitely in working with clients, but also their families, because this kind of education can allow them to have more compassion and empathy for what their teen might be going through. We're going to talk about the family stabilization plan. We're going to talk about some skills that families can use specifically in responding to their teen who might be struggling with suicidality. And then finally, we will end on interventions you as clinicians can use in your own practice in working with teens. And we'll leave some time at the end. I was going to leave 15 minutes, but because we started a little bit late, I'm going to leave about 10 minutes for questions at the end. So just to give us some stats to start with, one of the things we know is that suicide rates are the highest in men and in older men at that. However, when you look at causes of death, our teens actually have suicidality at the top of the list in terms of causes of death, just behind accidents, like car accidents and that kind of thing. So we know this is a national issue, international issue, in terms of how can we, as a public health issue, reduce teen suicide. And this has been a focus for the past several decades. unfortunately, even with this um, realization that suicide rates are high in teens, we have seen increasing rates over the last years rather than a reduction. So over the past 5 or 6 years specifically, we've seen suicide rates increase exponentially in our teens. So one of the things I'm going to be focusing most on today is teens. Another area, though, that's very ripe for research is in children. We are seeing children ages 5 to 10, or 5 to 12, I should say, that are struggling with suicidality. And each year, about 33 children die by suicide. That sounds like a low number when we're talking about in comparison to our teens and other age groups. But these 33 that died in 2022, that's the most recent stats that we have in the United States specifically. This is something that's very foreign to parents, that your child would want to die by suicide. And so how do we work with children is another area that's ripe for the taking in terms of developing interventions and techniques. So when we're talking about interventions that have been shown to be effective with teens, like I said, the pool is small. What we do know is that there is evidence that working with families increases the effectiveness of any techniques that are being utilized. So in looking at depression, which is sort of suicidality could be looked at as one symptom of depression. We often look at this as separate from depression because suicidality can happen with a variety of disorders. But in terms of looking at family involvement, there has been some evidence that family involvement has been really beneficial for depression. Again, we need more research in family intervention specific to suicide. When we look at working with families specifically, most of our families do not know how to talk to their teen about suicide. So one of the things we'll be talking about today is how do we train, or how do we educate our families in talking about suicide with their loved one. When we look at interventions for suicidality with teens, the only intervention that is classified as a well-established intervention is DBT for adolescents. So it has met that criteria in terms of reducing suicidal ideation. Specifically, it hasn't met that criteria yet for reducing suicide attempts. It's in the category of probably efficacious. We do see some promise with CBT, mentalization, and attachment-based family therapy. And then most recently, the collaborative assessment and management of suicide, the CAMS approach, has been showing promise in its adaptation for teens. This is what we use at Lightfully. We use the CAMS approach for all of our adults and teens. Those of you who are interested in getting this training, it is I have no connection to the training, or I don't get any royalties or anything like that in recommending this. That training is available through the CAMS website, and they have applications for adults and teens. And it is relatively inexpensive compared to some other kinds of trainings. All right, so let's dig into understanding the suicidal mind. I always tell attendees that if there's any slide that you take away from today, it's this next slide. The question is out there, why do people die by suicide? we are wired for protection. We will do anything, the way that we're wired from an evolutionary perspective, we will do anything to protect ourselves from dying. So what goes wrong when we become suicidal and want to die? What is strong enough and powerful enough to switch off that flip switch to make us want to die rather than to live? Well, first, suicide is the result of something that's called psych ache. I love this term. This term was coined by Ed Schneidman, who was the father of suicidality. And he was left with, in working with people who were suicidal, he was struck that there was not a word to describe the psychological pain behind the person's desire to die. So he coined this term psych ache. I love this term. Part of establishing a good rapport and really being able to understand the client in front of you is maybe to give them some words around what it is they're experiencing. So psychic can be that word. And when you've worked with someone who's suicidal, you will see they often you have their hands like this, because psychic is an emotion, a feeling, a thought that is centralized in the head and the heart. So it's you're tormented by thoughts of wanting to die on a cycle, and intolerable hurt and pain from an emotional perspective. So it's that combination that feels so intolerable that you'd rather endure the pain of dying than to withstand the pain of living. I also like what Thomas Joyner, his theory that I'll share in a second, looks at the three factors that converge to place a person at risk for suicide, which includes burdensomeness, lacking authentic connections, or what he calls thwarted belongingness. And then the tipping point is a fearlessness around death and an increased tolerance for physical pain. So I'll talk about that in a moment. So those factors, though, should be things that we have our radar up, that we're looking for when we're meeting with the client as risk factors for suicidality. The other thing that is a trademark of individuals who are suicidal is that they experience something called constricted thinking. Constricted thinking is an evolutionary process that goes awry. So I always give the example of, if right now something were to happen and a bear came into my office, this would be so bizarre, but I would immediately go into fight, flight, freeze mode, and everything would fade to the periphery except this bear. I would forget that I am doing a presentation, forget everything else that's going around me, just so that I can focus on this bear. That is evolutionarily adaptive. That is protective to my survival. That is what also happens during suicidality. However, this is something that works against us in those situations. When you're suicidal, the only option that you can see as the only solution to your problems is to die. And this is unfortunate, because if you could open up your vision, so to speak, to the periphery, you could see other options on the horizon. So I often explain this to clients when I'm working with them, when they can understand the concept of constricted thinking, and that this is what happens when you're suicidal. It can be an intervention in and of itself. So they can say, I'm experiencing constricted thinking. Right now, that's the only option that I see, and there are other options that I can't see. So this can be a really powerful discussion item for your clients. I also like to remind clinicians and families that suicide attempts are not attention seeking, they're help seeking. We'll often have new clinicians talk in this way. Maybe all clinicians, when they get really burned out, may say things like this. Or we'll have families say this. I think the reason we do this comes from our own fear and our feeling of ineptitude in working with someone or meeting their needs because we don't know what to do. So to make ourselves feel better, we say, this isn't real. They're just doing it for attention. So I don't need to worry. This is the only thing I can come up with of how we've gotten to this place of this is attention seeking. Because what we know is that the biggest predictor of a fatal suicide attempt is previous suicide attempts. So it would be really to our detriment to fall for this myth that they're just doing it for attention and they don't really mean it. So I try to help families and clinicians make a shift in this isn't attention seeking, it's help seeking. And it may be the only way that the only option that they're seeing in that moment. So we need to think about it in that way. And then finally, suicide is not selfish. When individuals kill themselves, they feel like it's the best option for everyone. They're in a place that they feel burdensome and that their families, their loved ones would be better off without them. So these are some things that are really important for families to know and for clients and clinicians for sure to know. So when we look at the conceptualization of suicide, there are several different theories of suicide. I prefer Thomas Joiner's conceptualization. So this is what we use at Lightfully. So Joiner says that 3 factors converge to place a person at risk for suicide. The first is burdensomeness. Now, burdensomeness can take on what I say different flavors. So the first is the sort of traditional flavor that you would think of. People would be better off without me. That's a very common example. But burdensomeness can take on a different look in terms of the psychological pain that the client is carrying, that the teen is carrying. That is a burden. And at times, it may be that the burden of carrying that psychological pain becomes so much that death feels like it's the only option. Another flavor of burdensomeness that I think is important relates to hopelessness. Many times our teens feel like there is not a way for them to get better, or what it takes to get better, they're not capable of. And so the burden of what's in front of them feels like it's too much. So I give those different examples because when you're looking for burdensomeness in your client, you want to have your radar up for the different presentations that it could take. The next factor that Joiner cites is what he calls thwarted belongingness. Nobody in the history of ever has said, I think I'm experiencing thwarted belongingness, right? That what we'll hear is I feel disconnected, I feel unseen, I feel unknown, I feel like nobody gets me. And this is a very important factor for our teens where in their path to suicidality, where they feel like everybody else has it all together, they don't, where it's on social media feels like everyone is showing their front stage perfection and they're living in their backstage imperfection. And we know that as kind as some kids can be, kids can also be cruel. And there is a cruelness that many of our teens have experienced in terms of being left out and feeling very alone in that way. The other factor that is really the tipping point in these 3 factors is an increased pain tolerance paired with a fearlessness around death. This is what Joiner refers to as an acquired capacity for lethality. Again, big fancy words, but what that really means is that I have developed the ability to kill myself. So to do that, you have to have an increased pain tolerance to endure the pain of killing yourself. And you have to have a fearlessness around killing yourself. How does that happen? Well, it happens in a variety of different ways. For our teens, what it may look like is that it could be suicide attempts, because you're a lot of times increasing the ante every time you make an attempt. Each one is more and more lethal, and that you develop a sense of habituation in that way, of an habituation to pain. Other factors can also increase pain tolerance and increase capacity for lethality. Things like drug use, especially IV drug use. So, as you're getting flirting with more and more very dangerous drugs, on that, in a blink of an eye could cause death, and you're flirting with death in that way, this increases your tolerance for pain and fearlessness around death. So those three factors converge to place a client or a teen at heightened risk for suicide. So this is what it looks like in action, is that we have the desire for suicide on one side that has the two factors of perceived burdensomeness and thwarted belongingness, which could be psychache and disconnectedness. So if you've got the desire for suicide on one side, that has to be paired with the capability of suicide on the other side. And that acquired capacity is the fearlessness around death and increased pain tolerance. And at that overlap, that's where those factors converge to place a client at risk. So what's important to know is that these do not happen, do not occur sequentially. What I mean by that is that you could start with the capability of suicide. So let's say I'm using IV drugs, and I self-harm. I may have some of those factors in that acquired capacity bucket. And then if I start to develop a desire on top of that, I'm at increased risk. You could look at it the other way, where it could be that you start with a desire for suicide and that capability develops over time. So regardless of what sequence it goes in, that overlap is the most important. We work with a lot of clients who have a desire for suicide. We work with fewer that have desire plus capability. When you've got that magic overlap, that is where your radar needs to be at in terms of suicide risk. So I talk about some of these things definitely with clients, and I talk about them with families. And understanding this conceptualization is part of what makes the next thing I talk about really work. I'm going to talk next about our family safety and stabilization plan. So all clients that are struggling with suicidality need a safety plan. This is not a no suicide contract. Those have been shown to be ineffective. So that's another thing that I always hope. I'm on a mission to eradicate no suicide contracts. So if you were trained to use those, please stop. They have not been found to be effective. In fact, there's some research that suggests they may actually be harmful. So what we should do instead is not focus on what you're not going to do, but to focus what we are going to do. So my recommendation is to use a stabilization plan in addition to a safety plan. A de-escalation plan or stabilization plan in addition to a safety plan. So we use this with all clients. Why? Because what I said before, even though a client may not have struggled with suicidality, they may have they may start to struggle with it at some point. If we don't have something in place to really intervene during those times, we're going to be at a loss. So we want to prepare ahead of time for that possibility. So like I said, we use what we call a de-escalation plan for clients who don't struggle with suicidality, which includes ways that they're going to de-escalate, regulate. And so I'll go over that a little bit. But the most important piece of this safety plan, so the client has an individual safety plan, but the most important piece for teen is family involvement, because the majority of teens live at home with their families. So We are going to talk about today a family safety plan that you'll be able to use with your clients. It's included in the slide folder that you got with your flow code. So you can utilize this, use it to your liking. We do not have it protected or trademarked. I'd love for everyone to use it if it's helpful. So our creation of the family safety plan was informed by Rudd and Bryan's crisis support plan, and then Job's, who I talked about earlier with Cam's, his stabilization support plan. So we create this collaboratively with the client and a family member in the treatment team. And so we look at this as a playbook to divert a suicidal crisis. And so we look at this as preventive, like I said before, that is like wearing a seatbelt. This may not be something you need to do with every client. Some of the items that are in this, we can adapt it to the client that's in front of us. And I'll talk a little bit about what that looks like. So the family safety plan parallels risk levels associated with suicide risk. So if we look at the different levels of suicide risk, we have low, moderate, elevated, and imminent. So at imminent risk, this is where the client has ideation, plan, and intent. It usually requires hospitalization. Elevated risk is where the individual is really struggling. It may have some ideation and plan, but they're able to utilize their safety plan to create safety. Moderate risk is associated with more of a general distress, where the focus here may be more on de-escalation. And then there's low risk, where here we're just going to focus on how we can regulate and use coping skills if distress arises. So there's 4 parts of the family safety plan. The first is the face sheet, which we'll go over. Then there's the safe environment. We will only use this portion of the family support plan for clients who do have some degree of suicidality, who are at that moderate or elevated risk. And so then what we use for everyone is stages of a suicidal crisis. For our clients who don't have suicidality, we call this more stages of a mental health crisis. So you can adapt it in that way. And then finally, we have quick at your fingertips resources and references that families can use. So this is part of the family safety plan packet that they receive. And like I said, you all can use whatever parts of this that you want for your own clients. So let's start with creating a safe environment. This is means reduction. So we'll be doing this with our clients who are at higher levels of risk, that moderate or elevated. So these are individuals who typically have a plan, they have suicidal ideation and a plan. So we are going to want to reduce access to means in the house. I have seen families who go really overboard with this and get rid of things down to pens, because you could stab yourself with a pen, and then or get rid of a fork, something like that. That is not my recommendation. If your loved one is at the level that you need to reduce that level of access to means, then it may be that hospitalization is a better option, because you're not equipped, your home is not equipped to be completely eradicated of all suicide risk options. So what we're talking about more is things that would have a more fatal outcome if you were to use them. So this could be like razor blades, scissors, and knives. We'd definitely want to look at guns. These are the number one way that teens kill themselves. So this is firearms. We want to lock up, preferably get them out of the house. But if that doesn't feel comfortable with family members, to have these locked up where the child cannot get them. So that's the first place to start. And then we also want to limit access to medications. And so these are things, your medicine cabinets. If you have pain meds left over from all of your kids getting their wisdom teeth out, you don't want to have those stockpiled at someplace where a child who may be struggling with suicidality could use them. So meds and guns are the first place that are areas that we focus on. And then we start looking at sharps. We start looking at things that are ligature risks in terms of ropes, belts, extension cords, and other substances. So like I said, where you're going to get the best safety is through getting firearms out of your house, or access to firearms out of your house. And then second is medication. So if you're working with a family and they feel overwhelmed, those are the two things that I'd focus on as a place to start. So you also want what we call a face sheet, where this is in one place everything that the family might need if they were to go to the hospital, or if the child or teen's suicidality increases to a level that is requires hospitalization. So you're going to have here the phone numbers to call, and all the medications ready. So even if you had to call an ambulance, you could hand this to them so they'd have all of the information at their fingertips. And then based on the education provided that I just went over as it relates to means reduction, you're going to want to collaboratively come up with a plan around firearms, medication, and safety risks. And that would be written into the safety plan on a sheet that looks like this. In helping families understand risks, factors, and warning signs and activators, there's a sheet in the bundle that can help them identify for their loved one what the risk factors are. So I've highlighted here, this is an example of a client that we're going to be talking about throughout the presentation, Katie. These, with her family, these were some of the factors that we highlighted. So she had major depressive disorder. She had a previous suicide attempt. She had broken up with her boyfriend. Actually, while they were in treatment, they got back together. But there's some tumult in that relationship. And then she also had a history of sexual abuse by an uncle. So these are some of the things that are also highlighted here that were ways that Katie was communicating and demonstrating that she was suicidal. She was talking about it, saying she feels trapped, no way out, feeling hopeless, isolating, participating in dangerous and risky activities. She would drink alcohol and get with her friends and get drunk. And She really liked to write poetry, but when she did, it would, during these times, it would be about death and about uh, separation, loss, and that kind of thing. So you can look over here. So as activators, we do, these are things that happen sort of as a factor that happen, a precipitating factor is a way to look at this, something that could happen right before a suicide. So these are examples: changes in relationship status. This was true for Katie. Changes in friendships, fights or arguments with loved ones and friends, trauma, worrying about assignments and tests. I will say that Katie was also diagnosed with generalized anxiety disorder, so we'll talk a little bit about that. And then feelings of loneliness. You can see here some of these examples of activators for her. So we complete this together, the therapist, the family members, and the client. You'll notice that there's a section for other, which is Katie put that not having her phone was an activator for her. Her parents, in their desperation, would often use access to her phone as punishment because that was the only thing where they felt like it worked, where that was something that she cared about. But when that happened, it also made her feel more suicidal. So the family was sort of at a loss. Like, we feel like we need to take her phone away so she can't be sneaking out to get with her friends to hook up to drink. But when we take it away, she becomes suicidal. So we feel like we're held hostage. So those are some of the things that we would work on with this client. And I'll talk a little bit about that as we go. All right, so this is, we call this our distress thermometer. We use this thermometer. We actually use this with all of our clients, by the way, not just our teens, but this is a way for our teens and their families to understand their different levels of distress. These correspond to stages of a suicidal crisis as well. So this could be used for clients regardless of whether or not they have suicidality, but it definitely should be used for those clients with suicidality. So the green is where we say it's a no distress zone. So these are the behaviors, thoughts, feelings associated with positive mental health and flourishing. Examples: spending time with friends and family. The yellow represents thoughts, feelings, and behaviors associated with mild distress. And so it might be feeling a tightness in your chest or wanting to stay home from school. Orange, distress is escalating, and this might be where you're crying. There's an example, lying on the floor. Red is more imminent risk. I want to die. I'm throwing things. I'm self-harming, etc. So one of the things that we would do is, if a client was in treatment with us, we would have them create their distress thermometer as one of the first things they do when they get to treatment. So they're looking at how distress shows up for them. And then we have them complete this as it relates to how staff can support. So you can see here the coping skills for each zone, and then how staff can support you for each zone. So we complete this at our residential levels of care. Within the first 3 days, a client does this. We tape it up on the bulletin board, so our staff have access to it. The client has access to it. So this is sort of a shorthand of what to do in these different situations. We then continue to adapt this as the client is learning skills and becoming more aware of what different levels mean to them. This same thermometer then is adapted for home use, so that if they're in our residential levels of care, then they, as part of the family safety plan, What do we do at home? What can mom and dad do to support me? And we definitely want this in place before they get home, so that we know how the family can be supportive. At lower levels of care, those of you who work in outpatient, the way you'd want to use this from the beginning would be, how can my family members support me? The staff piece wouldn't be as important, but how can the family support? This is a living, breathing document. So this would be something that we would continue to edit throughout treatment. So this is what Katie's looked like. This is small, but just as an example. And what you see here is that we've gone through and done thoughts, feelings, behaviors, and triggers for each level, and then coping skills and support for each level. And here you can see how Katie's come back and changed what she, or added to things that go in each column as she's gotten to know herself a little bit better through treatment. So this one is specific to the families. What I love here is that she also has some tips on things not to do. So when she's in severe distress, she doesn't want to be touched, so don't try to hug me. But in mild distress, ask if I need a hug. So this is really helpful for families, because oftentimes they're like, I don't know what to do. Sometimes a hug is good, sometimes it's not. As we start to outline these different levels of distress, it's obvious that the reason it seems like there's a catch-22 is that it depends on what level of distress I am as to what feels helpful. So as this client learns skills, you can see she's adding them in here, of things that she can do to cope. So this is a living, breathing document that clients use. And then it's transposed into the family safety plan or stabilization plan. So helpful tips with this plan. We want in completing this, families often feel like they are at a loss. So you're going to have to be more directive than maybe you typically would be in working with a family in creating this plan. And I think you can say that, of like, there are things where there are times where I'll say, hey, you get to decide. You're the parents, you get to decide how this is done. And even within this, there are those things. But in creating safety, there are some things where I'm going to be very direct and very directive. And so in those, it'll be important to point those out. You may even want to give scripts, which I'll go over in a second, for how parents can respond. And then you're going to want to use language that makes sense to the family system. The ways that the client talks about things will be the ways that you integrate this. One of my favorite things to do is role play this in session, because when it comes game time, if you haven't practiced, it's not going to go well. So my other pointer here is you can use this structure, but adapt it to your liking. And each family safety plan ends up looking very different, because even though it has the same bones, it's going to look very different based on the client. So each one will be adapted in that way as well. All right, so let's next talk about how to help family members respond to their loved one who may be struggling with suicidality. So here I'm going to focus on some skills that are based in what's called emotion-focused family therapy. This was developed by Adele LaFrance. It was developed specific to eating disorders. It can be generalized to all kinds of family difficulties and crises. What I also say to families is that this is just a good playbook for how to respond to a loved one when they're in some kind a level of distress. So these are just good parenting skills or good spouse skills, good partner skills. So EFFT, I love this quote. This is from Monin. What is most detrimental to the mental health of a parent or caregiver is to witness a loved one's suffering and feel helpless or ineffective in the face of it. And any of you who are a parent or a caregiver, you've been there. You know what it feels like when you feel helpless and incompetent in meeting the needs of your loved one, especially if they're in a place of high distress and it feels like you can't do anything to fix it. So at the core of EFFT are tools to help families feel more effective. Our approach with families, and I promote this same approach with all families, working with them as loved and their loved ones, they're doing the best they can. And they are coming from a place of desperation most times. But at the heart of it, in most cases, there are very, very rare cases where parents don't love their kids. But for the most part, in 98% of cases, this is coming from a place, whatever they're doing or not doing is coming from a place of where it started with it. They loved their loved one. It was a place of love. And now they're desperate and they don't know what else to do. So we really need to be looking at this through that lens of compassion, empathy, and everyone doing the best job that they can through that lens of generosity in working with families. When families come to us, they're going to feel like they're about to be blamed, and they often are. And they're coming in a defensive posture. From the beginning, if we're able to work through and sort of dissolve that armor, these interventions will be even more effective. So EFFT is part of that. It was, like I said, originally developed to support teens with eating disorders, families of teens with eating disorders. It's a transdiagnostic approach that really can be applied to any problem and any level of distress. And it pulls from family-based therapy, motivational interviewing. You can see some of these others that it pulls from. The foundations here are that this is a skills intervention. It's very heavy skills intervention. And that as part of teaching these skills, there's skills in 3 categories: behavior support, emotion support, and healing, what LaFrance would call like healing wounds, but it's really healing ruptures in the relationship. What we're going to focus on today is just on the emotional support piece. But if you're interested in learning more about this, there are a lot of different webinars and resources related to EFFT through the Emotional Focus Therapy for Families website. You can see that up here at the top of this slide. So this is the fundamental belief, is that difficulty with emotion processing is what exacerbates problems, because if the loved one, the client, the teen is in a place where they're not able to process emotions, whatever the family member is trying to do to help isn't going to work. We have to address the emotional processing first. And the other piece of this is that a lot of times parents, when they learn these skills, are like, oh my gosh, was I always supposed to be doing this? And I just am a bad parent because I wasn't doing this. No. Most of the time, if your child isn't struggling, you wouldn't need these skills. These are nice skills to have. You can use them with your other kids. But the reason you need these skills is because your client, your loved one, is struggling. So the skills you were doing before, we talk a lot about good enough parenting. Thank goodness research shows that you don't have to have perfect parents. There's no such thing. Good enough parenting works just beautifully. And we all can fit into that good enough category. These skills are advanced skills for when your loved one is really struggling with a mental health disorder. All right, so it's a two-step process. This is the one that we usually skip, by the way, and we do it with our clients too. We forget to validate. Before you support, you have to validate. So validation is so important as part of settling an emotion that EFFT has you do it 3 times. So you're going to validate, then provide support. We don't do it that way, right? We try to do support and then I think we just skip the validation most of the time. So we can't do emotional or practical support until we validate it. We also want to remove buts from our process. So for instance, if you were to say, I can imagine why you're upset because of this and this and this. And then you say, but you have to go to school anyway. The but has just negated the whole validation. And so I love this. This is from LaFrance, that she would say, but indicates that it is inconvenient to me for you to be feeling this way. That is the message behind the but. What I also like to say is, therapists love this, and is just a but in disguise. So, we're all trained to say, just let's use and. It sounds so much more connecting. It's a trick. So if you were to say, I can understand why you're distressed, that you don't want to go to school because, and you need to go, Johnny, because grades are due Friday. Whatever. That was just a but in disguise. So we're going to eradicate buts and fake buts. Okay. Oh, I get myself so tickled. Okay. So when we do this, we are diffusing emotional distress. So if you think about emotional distress on an elevator, what we typically do, we try to support. So the clients that your loved one, let's say that your teen is up here and they're at floor 30 and in terms of distress level. And we're down here on floor 1 and we're trying to apply logic. We're trying to provide support. They can't hear us. Nothing is going in. And then we're frustrated because this isn't working. So what we have to do is we have to come up here to floor 30 with our loved one, and then we're riding the escalator down. So how do we do that? We follow this script. I can imagine you might feel blank because, and we're coming down the escalator down to floors 12. That's the first one. And because now we're at the ground floor. And so I now am trying to support a de-escalated human rather than an escalated human that isn't going to be able to hear. Now, you might say you're, well, like I don't need to use these skills right now because little Johnny isn't in distress. I only need to do it if it seems like he's really activated, like in that red zone. And I would say that's a mistake. Anytime you want to validate or anytime you want to provide any support, you need to start with validation. So here's what this can look like. So here's an example of what a non-validating, a non-EFFT statement might be. So you're taking your kid to treatment. I know you feel sad that you have to go to treatment, but it's what your therapist thinks is best for you right now. It's all going to be okay. How many times, I think that'd be a very common thing that someone might say to their teen. Instead, you're going to say something like this. You can start to drop the becauses as you get a flow because it won't sound so stilted. But for training purposes, I've got the becauses here because you do need 3 times. It makes sense that you're feeling anxious about starting treatment because it's your first time and you don't know what to expect. because it feels lonely to be disconnected from your friends, and because being away from home and your family feels unbearable. You can get a flow with this where you could say, I can imagine you're feeling anxious about going. And it's your first time. You don't know what to expect. And I can imagine you don't know, you feel like you're going to lose touch with your friends and you're going to be away from home. I just did 3 becauses and it was a little bit less stilted. And then after the 3 becauses, we say, I can see how hard this is for you. And I'm proud of you for making this courageous decision. I believe in you. I'm going to be here with you. You don't have to do this alone. Then I've provided the supportive comment after the validation. So some helpful reminders. We're conditioned to be problem solvers, right? As family members, especially, and even as clinicians, we want to be a solution and provide a solution. And so it feels like there's something missing when we validate. It feels like it feels awkward. So it also can feel strange validating something for families, validating something that they don't agree with. And as clinicians, we understand how this works. We validate things all the time that we don't agree with. And we know how important validation is, and it's a moot point whether or not you agree, but families don't know that. And often they may be afraid that their validation will suggest that they agree or that will promote, make things worse. So that part of the discussion can be really important, of the power of validation and what it does and doesn't do, and that you don't have to agree. Also, what we're looking at with this, we're not looking at like the example that I just gave, that little Johnny is going to be like, oh, thank you, Mom. That's what I needed to hear. Let me pack my bags myself. I'm ready for treatment. No, that's not what's going to happen. It's going to be just a 1 degree shift is all we're looking for. Johnny is still going to say, I don't want to go to treatment. And you can keep validating and we're going, validating and we're going. And that can still create a degree of shift that is cumulative, that can eventually result in Johnny going to treatment. He may not be happy about it still, but going. And that is what you're looking for. I think it's important for us to look at EFFT for validating suicide. Families, as you can imagine, it's hard for clinicians to validate around suicide. I am of the opinion this is one of the most important things that we need to validate as clinicians. And I say to clients all of the time, I can imagine why you want to kill yourself. The lens from which you are viewing the world right now, it feels like it's the only option. You're in so much pain. It feels like you do anything to make it stop. And it feels like it's never going to get better. There's a 3-point validation. That does not, I have not just said, I think you should go kill yourself. That is the opposite of what I'm saying. I'm saying, I understand how you've gotten here. For families, that's sometimes hard to say. What we can validate is hopelessness. So looking at your teen as sort of being in a cave of hopelessness is what we are validating, this behind the suicidality. So what we're doing, instead of trying to pull them out of the hopelessness, we're going into the cave. We're going into the cave of hopelessness. It's kind of a scary place. This is hard for families because to go into the cave of hopelessness, you often have to address your own hopelessness. Most of us have our own caves, right? I mean, as therapists, this is hard too. So, but this is an important part of that empathy and validation, is we're going into the cave of hopelessness. And so what this might look like is if your teen says, I can't do this anymore, I just want to die. you can validate the hopelessness behind that suicidal statement. I can understand why you feel hopeless because you've been struggling for a long time. You feel like you can't see the light at the end of the tunnel, and it feels like nobody gets it. And then I don't know when or how, but I do believe it will get better. You are not alone in this. I'm here for you. I love you so much. And you can provide practical support too, of like, why don't we watch a movie together? And this template is very helpful for for families who feel like they don't know how to respond in these situations. So these are some good examples there. Well, I want to spend the rest of the time looking at interventions that, as a clinician, you can do with teens struggling with suicidality. The lens through which I'm going to be looking at this is the model that we use. Our model, we call it the precision care model. I like to say it's powered by process-based therapy. If you all are not familiar with process-based therapy yet, you should be. It is the wave of the future. We're moving away from syndrome-specific protocols and moving toward an integrative approach. Those of us who are clinicians and not researchers have been saying for years, that's what we've been doing, people. Let's do research that matches it, right? None of us are robotic and just do CBT session 1, session 2, right? We bring in a little CBT here, a little DBT there, a little somatic there. We've been doing this. Finally, process-based therapy is an approach that supports that integration. And so our version of this, we call it the precision care model. And the reason we've used those terms is that we just think it's a little bit more user-friendly. It's looking precisely at the drivers behind mental health symptoms. And we target those drivers with an integration of interventions specific to the driver. That sounds, wow, what is this? Let me give you a little bit more. When we're talking about drivers and in process-based therapy, Stephen Hayes and Stephen Hoffman are the founders of process-based therapy. Many of you may be familiar with Stephen Hayes. He's the founder of ACT. They talk about processes. That term gets a little bit confusing for our clients, or even our clinicians. So we use the term driver. I really like the term driver because it also aligns with Jobs's term driver when we talk about suicide risk in the CAMS model. So there are negative drivers and positive drivers. So when we're looking at symptoms, we've got like the client comes in, they take the PHQ-9, they have depressive symptoms, they take the GAD-7, they've got anxiety symptoms. Oftentimes we stop there and we say, we're going to use evidence-based interventions for depression, like CBT, whatever. In process-based therapy or precision care model, we go a step further. We say, we need to know what's behind this. We need to know what is pushing up into those symptoms that may have contributed to the development of the symptoms and definitely contributes to the maintenance of those symptoms. So what is that? It might be emotion dysregulation, low self-compassion, fusion with negative core beliefs. You can see some examples here. There are also things, positive drivers, and this is really important too in working with suicidality, looking at what are my drivers that I already have in place, or what are the client's drivers they already have in place that push toward well-being. And so it could be examples of where the client is emotionally flexible, examples of where they have mindfulness. So we want to capitalize on positive drivers and reduce negative drivers, or break the cycle of negative drivers. And that is what is at the root of process-based therapy or the precision care model. So we will be looking at the 3 steps. These are the 3 steps, 3-step formula in process-based therapy or in precision care model. assessment, conceptualization, data-driven clinical decision-making. So our first step, if we're looking at this teen who has come to us, they say they're struggling with wanting to die. So that's one of their symptoms in the iceberg. That's one of the symptoms up here. We're going to want to know what is below the iceberg that is fueling that. What is a driver of their suicidality? And the assessment phase is where we're going to find that. Then we want to develop a case conceptualization, which is like, we know this client is suicidal and this is what it's driven by. Simple one statement conceptualization. Then we want to select interventions that match the drivers, not the symptoms. Symptoms might look similar. We may have 20 clients in front of us who have the same symptoms, but their drivers are very different. So treatment's going to look very different based on those drivers. So let's start with assessment. So hopefully you're using a variety of assessments in your practice. We use a variety of assessments in our practice. We use symptom checklists. We also use driver assessments. And this is an example of a driver assessment that we use. This is from CAMS, the Collaborative Assessment and Management of Suicide, Collaborative Assessment and Management of Suicide. Sorry, are y'all seeing my teams come through? Okay, sorry, should have turned that off. Secondly, this worksheet is in your little bundle that you got. So here, what you're going to be looking at is first, there's two sections where we're figuring out what the drivers are. So first, we're looking at if the client says, I want to die, this is my recommendation on how to complete this. So first, you're going to look at what are the direct drivers behind that suicidality. So what are the specific thoughts? So this is an example of this client, Katie's. I should die. No one wants me here. This will never get better. Something's wrong with me. I'm a failure. Here's specific feelings: hopeless, overwhelmed, panic, angry, shame, behaviors, self-harm, throwing things, sleep too much, compare myself to others, and then specific themes. So after we have completed this section, it helps us streamline into the two drivers of suicidality. So when we look at the worksheet, it says problem number 2 and problem number 3 on the worksheet. Those problems are in reference to problem number 1 being suicidality, if you're looking at a treatment plan. But the way I think about this is these are the two drivers that we're going to center on. And how do we get there? Well, we got there from the themes of these thoughts, feelings, and behaviors. We were able to synthesize those into, I don't like myself. I don't think I deserve a life. So that's synthesized into self-hate. I have big feelings and I don't know what to do with them. And then, so big feelings is number 2. So what we've essentially done here is created a case conceptualization in a simple way for our client's suicidality. So Katie, her symptoms of suicidality are driven by self-hate and emotion dysregulation. So if this is my conceptualization, I now know what's behind this, what's underneath the iceberg. I can target interventions to self-hate and emotion dysregulation. Process-based therapy, AKA the precision care model, integrates interventions, the effective ingredients across all evidence-based modalities. Nicole Siegfried didn't come up with these. Hayes and Hoffman did a huge project actually called the Death Star Project, in which they looked at what the effective ingredients are across psychotherapies and across the change process that are at the root of recovery. So this is what they came up with. if you look at every evidence-based modality, it's going to have ingredients of these. So as part of process-based therapy, instead of getting trained, say, in CBT, the way the field is moving is that people are going to get trained in these interventions to be able to integrate them in a meaningful way for the client in front of them. This may take decades to get there, obviously, but this is what we're using in our facilities. So here for Katie, what would be some of the interventions where we'd want to start? Well, here, if we're looking at big feelings, we're going to look at arousal reduction, mindfulness, emotion regulation, and acceptance as examples of where we may pull from different interventions. Whenever a person has emotion dysregulation or a flavor of emotion dysregulation as a driver, I tell our clinicians that's where you start. Why do I say that? Because no other intervention is going to work with someone who is dysregulated and outside of their window of tolerance. You'll be wasting your time. So we have to get emotion regulation on board before other interventions are effective. So that's one of the ways that clinicians can, sort of a little tip of the trick of the trade is, I don't know where to start. If emotion dysregulation is part of the presentation, you know where to start. So this is where we would start with Katie. And then we might move into interventions for self-hate, looking at compassion-focused interventions, modification of negative core beliefs, and some of the interventions here. All right, so let's see what that would look like. I'm just going to use some examples of things that we did with Katie that you might, that might be helpful to you. There are a wide range of interventions within each of these bubbles that I have here that you can choose from a variety of different modalities. So the first thing that we did with Katie was around this distress thermometer, feelings thermometer that we already talked about in the family stabilization plan. So we'd had her complete her own distress thermometer, and I showed you the example of that in the family stabilization plan, the family safety plan. But we started looking at skills that she could use when she's up here. So the skills that we're looking at from a distress tolerance skills perspective are from DBTA, DBT for adolescents. And these skills are separated based on where you can get the most bang for your buck, which level of distress. So this handout is in your folder, but we started with her for stop skills and tip skills. And you saw that was added on her distress thermometer at some point, like putting her face in cold water was something when she's in red that can dissolve some of that distress. And so we started there so that she has some tools in her tool belt for those high level of distress situation. Then we taught her about the window of tolerance. There's different versions of the window of tolerance, and you can use whatever version floats your boat. I actually like Dan Siegel's model that looks at the window of tolerance as between hyperarousal and hypoarousal. So indeed, a window between them, and we're trying to widen that window. But you also might prefer Deb Dana and Stephen Porges's approach, which is the nervous system ladder, the arousal ladder. So choose your poison, choose whatever floats your boat there. I used to think that this window of tolerance might be too advanced for teens, because when we're talking about words like hyperarousal and hypoarousal, those sound kind of sophisticated. but you can adapt language accordingly. So when you talk about hyperarousal, you can say things of like, these are the times you feel really freaked out and you feel like you can't do it, you can't get through, and your heart might be beating fast. When you describe what hyperarousal is, then you can back into that term. And I've found that even our teens really get this once they get language for it. They're like, oh my gosh, yes, I do this all the time. I'm zoning out. And I do that actually when things get really bad. That's what I go to as I just zone out, you know? So mapping this out of what hyperarousal looks like for them and hypoarousal looks like for them is one of the first steps in widening that window. Getting to know your window of tolerance is an important aspect of this. Everyone has a window of tolerance, even if it's this tiny and small. So what does this look like? So we call this your optimal zone of arousal. And you've got a handout for this. So this is something you can use of what does it, when you're in that little window, your optimal zone might be really small right now, but what does it look like for you? What do you feel? What do you experience? What are you doing? I like this because kids tend to like this better as well. Of is there an image that goes with this? And so I've had kids, this is where they do like a little artwork into this. And so they're holding their dog, listening to music or something. So that often makes this stick a little bit more, where and kids will start to use terms for it of like, that's my dog zone, like where they'll do little shorthands of what their optimal zone is. So this would be what we'd want in place first. And this is what we did with Katie. And by employing some of these skills in treatment, she was in residential with us, we were able to decrease the number of panic attacks, high distress kinds of presentations, those episodes for her relatively quickly within the first couple of weeks. And as she was learning skills and naming how she was feeling. So we were able then to move into some self-compassion techniques. So the three things we're going to focus on here, and this is what we did with Katie, was getting to know her inner critic, building the compassionate self, and practicing self-compassion. So Katie was able to identify this voice in her head that was really hard on her. And the voice that hers had could be really harsh and really had an angry tone. And so we started getting to know that inner critic. Now, this is a little bit different than many of you may have been trained in terms of how to work with that negative voice in your head. From a traditional CBT approach, the intervention might be cognitive restructuring. I'm not a fan. I like to say I'm a recovering CBT therapist. Maybe you all would be part of my support group. I have found in working with clients that traditional cognitive restructuring can sometimes fall flat. It does work with some clients, and especially with kids who've not had this before. I've found that it can work as you're trying to build your positive voice, and you can do that. This was not Katie's first rodeo in terms of treatment, and she kind of rolled her eyes at positive self-talk. So what we did with Katie, and this is what I'm more of a fan of, is getting to know the purpose of your inner critic. It's hard to believe sometimes, but your inner critic, that negative voice, has a positive purpose for you. It was developed in a protective fashion as a way to get you to straighten up and fly right. And what you'll notice is that that maybe the reason that it's so harsh is that it needs to kind of pull you up by the bootstraps, is that feeling of like, and get you back on track. So understanding why the function of that voice and when it comes up and why it's there and maybe how it developed, because it may have learned from experience, and it could have be the voice of a coach that was hard on you or a parent that was hard on you. And so you'll start to see, oh my gosh, those words are the exact same words that mean coach had said to me. It may or may not be based in truth. And so that's one of the first things that we want to talk about is that to what degree do you believe me when I say that your inner critic may not be accurate? At first, clients will say, oh, I don't believe you at all. It's 100% right. And it might take some time and some examples for them to realize, oh, it's quick and efficient, but not always accurate of like some of the things that it may be telling me and how it's apprising the situation. So what we want to do in working with the inner critic from this perspective, instead of talking back to it and eliminating the inner critic and building your inner coach, we're not doing that. We're not going to eradicate the inner critic. We are instead going to build the compassionate self. The compassionate self can have compassion for the inner critic. In fact, I just demonstrated that. The minute that you say, oh gosh, I understand the protective function the inner critic has, I just showed it compassion. So actually, what happens when you start to do that is the inner critic isn't as loud. Over time, at first there's some backlash, but over time, it's not as loud. And so, again, we don't want it to go away. It serves a purpose, but how can it partner with the compassionate self in protection? So how do we build the compassionate self? Those of you who use compassion-focused therapies are very familiar with the compassionate self. I like to think of the compassionate self, again, from this integrated approach. I really like the concept of self from IFS that looks at self as our inner core. Everyone has a self. So it's just a matter of getting in touch with it and building it. I like to look at the compassionate self as part of that. And so how do you know you're in self is if you're demonstrating one of these 8 C's of self: curiosity, clarity, compassion, confidence, courage, creativity, connected, and calm. So we start to try to build the compassionate self. And how do you know you're building the compassionate self? Often you're building it sort of sideways because you could be building it through curiosity. And so that's one of the first ways into self is through curiosity. If you can create some curiosity in your client, it opens them up because it holds hands with all of these other aspects of self. So we started doing that with Katie, looking at places she could be curious, using what we call some of her noticer skills, and approaching things through that lens. And so we started with curiosity. The compassionate self does not try to eradicate the inner critic. Doesn't work. Just even do it for yourself. If you've ever tried to talk back to your inner critic, you're going to lose because it's had 55 years in its position, right? So you're not going to beat your inner critic, but you can have compassion for your inner critic. And that is kind of a different approach than maybe what we've traditionally done. Kids love this compassionate image exercise that we do, and we did this with Katie. I used here just an example of, this is the fairy godmother from Cinderella. Kids have used that before. First, because it's so hard, especially as a kid, to feel that internal place of compassion, calm, self-connection. At first, they may have to think of compassion as outside of themselves. So they may think of someone in their life that demonstrates that for them, and that can become their compassionate image. There are times they can't think of someone that fits that mold, and then they might instead use an image from a video game or a movie. And the exercise here is starting to use that compassionate image and starting to say, what would my compassionate image say for this? You'd name the compassionate image based on what their image was. So what would my grandmother say about this? What would my fairy godmother say, whoever it is? And that becomes a way in. And then finally, we want to start the practice of self-compassion. And this is something that indeed, we often don't think, we think of self-compassion as a trait, but it's really a practice. I love Kristen Neff's approach to self-compassion. And this is something that we can start young with our kids of how can they start practicing self-compassion at a young age so they have it when they're needing it, as they need to have that for themselves. Our teens probably haven't been practicing self-compassion, the teens that are with us in treatment. So we train toward this early on. So there's 3 steps in the practice of self-compassion. The first is mindfulness, which is approaching the situation without judgment. So you do need access to your compassionate self for that, or your compassionate image of how would my compassionate self approach this fact that I just failed this class? What would my compassionate self say? That's the first one, approaching this with mindfulness, no judgment, curiosity. A second one, I go out of order here. I do mindfulness, the 3 steps, then I do connectedness, then I do self-kindness. But so connectedness is reminding ourselves we aren't alone, that what Neff calls this is common humanity. I don't use that term with kids. I'll usually say ways that you can feel like you're not alone, or that you can connect to others. I use stats for this, in terms of mental health struggles, 1 in 4 teens is going through something right now. So I know this is a little off in terms of stats, but look around in your classroom. 1 of 4 of you is struggling just like you are. And so remembering that, that you're not weird, you're not alone, is a big part of this. And then demonstrating self-kindness. How can I be kind to myself? It could be that I say something kind to myself. That just in and of itself is a self-kindness. I can do something kind for myself. And that can be as simple as holding Katie, holding her dog. So this practice is something then that can be ingrained as well. So these are some of the things that we did with Katie in terms of the interventions that matched her drivers in terms of her suicidality. And what you see is that we had obviously safety planning and the family support as part of that. But then we also were doing therapy that was targeting the drivers of those symptoms. So a takeaway for you, if you're attending this, is knowing that in working with clients, there are like 3 areas that I can work with my team. The first is responding to the crisis stabilization, safety planning. Integrating families is the second, and teaching them how to respond in crisis. And then third, applying interventions for the drivers of the teens or adult client, for that matter, of their suicidality. All right. that brings us to the end. I've got this flow code here again where you can take a picture. It takes you to the handouts and to the copy of the slide deck. So we've got about 10 minutes for questions.
Nicole, thank you so much. I think I
Yes.
speak for everybody about how helpful this was.
Oh, good.
And I'm getting lots of comments about how helpful and how everyone would love to have the resources that you're talking about and sharing in this presentation. So just a quick announcement, I did post the link to the resources. If for some reason you're having difficulty accessing the link, we will send out an email following this with the recording as well as the link and attachments of those in case you can't get into the link. We've got a couple questions that
Good.
folks threw in the chat, so I will pull those up for you, Nicole. The first one looks like it's from Allison. It says, I have a client who just cannot get behind being more compassionate towards herself. Any ideas about how to get her on board with this concept?
I would start with, and whoever it was that said that, Allison, you're not alone in this. This is one of the toughest things for clients to grasp onto because it feels threatening to move away from self-hate. Because if you think about this as protective, if you are doing something different, it doesn't feel safe. So validating this can be very powerful for a client. Of course, it makes sense that being compassionate towards yourself feels threatening because it feels like you're going against one of your safety tactics. So what I would start with is some of the things we talked about here. I wonder if she could have compassion for how this part of her that's been so hard on her and the job that part has had to do. I've had clients, one of the exercises we have clients do is create a job description for their self-critic. I mean, it is a 24/7 job. They don't get off on nights or weekends. And this part is exhausted. And the only tools it has in its tool belt is just to do more, harder, faster, meaner. And so if we can start compassion there, that can be helpful. I also would explore the client's fears around self-compassion. This is something else we do. There's a scale that Neff uses called fears of self-compassion. So I'd have your client, take that quiz to identify her specific fears of self-compassion. And that might be revealing because most likely it's going to be around things like myths of self-compassion, like self-compassion is self-pity, self-compassion is going to let me off the hook. And so that might open the door for where some of those fears originate.
So helpful. We have another one from Yvonne. It looks like this is around when you were talking about validation and validating feelings. She mentioned that she says, sorry, what about a client that reports hearing voices and it's voices commanding a suicide? What does validation look like for someone
So
like
good.
this?
Yes. We get this all the time. We have clients with this as well. What we validate there is the distress. So sort of the way that she would validate the hopelessness for someone who's suicidal, you can evaluate the distress of the voice or the hallucination, like how distressing I can imagine how much distress that is when you're hearing you should die, you should kill yourself. As you know, if you've ever tried to talk someone out of a hallucination, it's not going to get very far. So I do not recommend that, trying to negate a hallucination on coming in hard on that. But what I would do is validate the distress behind it.
Yeah. So helpful. Thank you, Nicole. I know that we're bumping up right against the hour, and we know that all of